All right, so I'm going to go ahead and get started. Again, my name is Dave Shidlow. I'm a cardiologist at Children's National Heart Institute at Children's National Medical Center in Washington. I am a pediatric cardiologist and a fetal cardiologist, and today I'm going to be speaking for the next 50 minutes or so on fetal echocardiography and perinatal management of the neonate with high-risk cardiovascular disease. And there will be some time at the end for questions if anybody has any. So before we get into the meat of things, I wanted to start with a little bit of a tale here. And it is a tale of two transpositions, transposition of the great arteries to be specific. And the first patient with transposition had good prenatal care. And this is a view from the obstetric ultrasound of the four chambers of the heart. And as you can see, there is a normal right atrium, right ventricle, left atrium, and left ventricle. So for all the world, this looks like a healthy, normal heart. But this baby was born by C-section for a previous C-section. But after delivery, shortly thereafter, there was cyanosis that did not change with oxygen. And an echocardiogram at a remote hospital showed transposition of the great arteries with a nearly intact atrial septum. And to give you a sense of the distances here, so we're here in Washington, and this is a true story, but I don't want to give any hospital names away other than Children's National. And the patient came from a distance of about 120 miles away. So that gives you a sense of just how far this baby came from and how that may have influenced the course thereafter. So the baby was started on prostaglandin at about 4 hours of life and was transported to Children's National. The time it took to get an atrial septostomy, that is to open up the atrial septum so that oxygenated and deoxygenated blood could mix, was about 11 hours. And unfortunately, the preoperative brain MRI showed some stroke, and the stroke resulted in a delayed corrective operation, the arterial switch operation, and ultimately severe left ventricular dysfunction. After the surgery, the patient required ECMO, or extracorporeal membrane oxygenation, which was complicated by pulmonary artery thrombi, which required cardiac catheterization to open up or recanalize the pulmonary arteries. And unfortunately, the baby was unable to separate from ECMO and ultimately required palliative care. Now, that is not to say that the lack of prenatal diagnosis in this case was responsible for all these things, but it does beg the question, what can fetal cardiology offer in this or similar scenarios? So with that in mind, here's an overview of the rest of the talk. I'm going to spend some time talking about fetal echocardiography and its abilities and its limitations. This is not meant to be a comprehensive fetal echocardiography talk that could take an entire day or several days, but I do want to give a sense, again, of the abilities and limitations. We'll talk about delivery planning. So what happens when we identify a child with congenital heart defect? Specifically, we'll talk about a level of care system, and then specifically spend a little bit of time talking about those deliveries that are high risk. And then I do want to thread throughout this presentation the benefits or potential benefits of prenatal diagnosis. So as you can see from this slide, this is a number of clips from a normal fetal echocardiogram. And as you can see, we can get really exquisite detail in terms of the cardiac anatomy. And I'm sure that doesn't come as a surprise to many people on the call who are familiar with fetal ultrasound or fetal echocardiography. But this is a normal four-chamber view, right ventricle and left ventricle. There's the foramen ovale up there. This is a nice picture of the aortic arch with the head and neck vessels arising from it. There's a beautiful short axis picture of the heart. We can even see the two individual leaflets of the mitral valve. Here's a nice picture showing the ductus arteriosus connecting it to the descending aorta. And for those on the call that routinely do a fetal echocardiogram, you know that there are several components to the fetal echocardiogram in multiple views. In the background, you kind of see just how many different elements there are to a normal fetal echocardiogram. This is a highly detailed examination and really allows us to detect the majority of important defects. Single ventricle congenital heart disease, certainly, large ventricular septal defects, chronotruncal abnormalities such as transposition of the great arteries or tetralogy of Fallot, gives us a good sense of ventricular and valvular function. We can detect effusion or hydrops, and we can assess heart rhythm. So what follows are just a few examples. So here is an example of transposition of the great arteries. Here is the left ventricle, here is the right ventricle. And as we sweep up to the outflows, we can see that there is a vessel here that branches into a left and right side, making it the pulmonary artery arising from the left ventricle. And from the right ventricle, we have a vessel that does not branch, and this turns out to be the aorta. And this parallel arrangement of the great arteries is typical for transposition of the great arteries, but it also goes along with a number of other congenital heart defects, such as double outlet right ventricle. Here's an example of complete common atrioventricular canal. So that means that there is an abnormality in the endocardial cushion portion of the heart, or the center or the crux of the heart. Here is a large atrial septal defect. There's a large ventricular septal defect, and there's a common atrioventricular valve. More subtle but detectable are pulmonary venous abnormalities. So this is a two-dimension color compare image, and this is the posterior part of the heart. And what we can see, mainly on the color image, is that there is a large vessel going inferior under the diaphragm and then coming back up to the right atrium. And this is a classic finding for infradiaphragmatic pulmonary, total anomalous pulmonary venous connection, which is a rare but important disease, especially when it can be detected prenatally. And I'll go into a little bit more detail in a few moments. We can also detect heart rhythm abnormalities. Here again, just by way of orientation, this is the left ventricle, this is the right ventricle, and you can see that there is some abnormal heart rhythm going on, both up here in the atria, something looks unusual, and down here in the ventricle, something looks unusual. And by using M-mode, we can actually sample the ventricle and the atria, and what we see are that there are 2 atrial contractions for every ventricular contraction, making this atrial flutter, this 2-to-1 conduction. So I think that this illustrates just how much detail we can get into in terms of fetal echocardiography. But there are some important limitations which are important to share with families. Certainly minor defects are difficult to detect. Atrial septal defects are particularly difficult because there is a normal foramen ovale in the fetal heart. So it's a fetal atrial septal defect, if you will, making other defects very difficult to detect. Smaller ventricular septal defects, particularly in the membranous or muscular region, are difficult to detect, and other milder abnormalities such as bicuspid aortic valve, other minor valve abnormalities, or partial anomalous pulmonary venous connection. Coarctation of the aorta also turns out to be something that's a little bit difficult to detect, and that's because oftentimes coarctation of the aorta does not develop until the ductus arteriosus closes, and the ductus arteriosus, as you know, is a normal fetal blood vessel. I included a few slides here just to illustrate the detection rates of prenatal diagnosis. This isn't a limitation of fetal echocardiography per se, but it is really more speaking to a limitation of the system. Despite our ability to take exquisite pictures of the heart and get a lot of detail, the prenatal diagnosis rate of many forms of congenital heart disease is still rather low. Here you can kind of see a spectrum ranging from about 9% for total anomalous pulmonary venous connection up to about 65 or 70% for many forms of single ventricle congenital heart disease. There's some important reasons for that, but it is important to bear this in mind that one of the limitations is, again, one of the system and not so much the ability to image a specific heart defect. This certainly varies by region, and this is overall rate of prenatal diagnosis. And you can see here in our region, in the Mid-Atlantic, 46% prenatal diagnosis rate, but that is the highest throughout the country. Importantly, those diseases that have an abnormal four-chamber view, such as single ventricle congenital heart disease or a complete AV canal defect, have a statistically significant greater likelihood of being detected prenatally. So you'll see these where the four-chamber view is normal, again, transposition, tetralogy of below, truncus. These are not as readily detected, mainly because, at least the thinking is that the outflow tracts need to be imaged for these lesions to be detected. And this speaks to the need for high-quality obstetric screening. In terms of indications for fetal echocardiography, that could also take up an entire hour. But in general terms, fetal echocardiography is recommended when there is a greater than 1% risk of a congenital heart defect. So you can see that the indications are rather expensive. They're listed for you here. And just as important is that there is a list for which fetal echocardiography is not recommended, and those are listed for you here. It is important to note, however, that when we see patients in our fetal echocardiography or fetal cardiology clinic, the greatest likelihood for identifying a heart defect is when the obstetrician or maternal fetal specialist suspects there's an abnormality in their heart screening. So again, another important plug for high-quality obstetric or maternal fetal screening. So now that the diagnosis is confirmed, what do we do with this information? Well, certainly a number of different things. For the family, understanding the cause of the abnormality is very important. Certainly from a genetic perspective, families want to know if there were environmental factors that played in. And certainly, in terms of future pregnancies, that is an important consideration for the family. Some families may be decision-making surrounding the continuation of pregnancy, and some families, many families need psychosocial support. That turns out to be a particularly important aspect because we know from this study that receiving the diagnosis of a congenital heart defect in the prenatal period was associated with a higher maternal psychological quality of life. But there is certainly stress after the prenatal diagnosis of congenital heart disease. So there is an opportunity to alleviate some of that stress here. Again, in terms of understanding the significance of the congenital heart disease, the families can know for pregnancy, for the perinatal period, for surgeries and medications, and for childhood and long-term care. All of these things can be discussed extensively with the family. Another important aspect is coordinating during the pregnancy all of the care that's going to be needed in terms of working with a maternal fetal specialist or obstetrician. You know, we are experienced cardiologists, but not necessarily experts in fetal well-being or fetal growth, so we definitely have a collaborative relationship. And then other specialists as necessary. As one can imagine, oftentimes there are genetic or other abnormalities. So that collaboration with other specialists, both prenatal and postnatal specialists, is important, and certainly social work to help families. And then one of the main focuses of what we do is talk about delivery planning with the families to ensure that those families who are affected by the diagnosis of a congenital heart defect have the optimal care to ensure the best possible outcome for their babies. So in so doing, we need to consider that there is a range of pathology and physiology. For example, a child with a complete AV canal defect may have a different type of physiology than someone with transposition of the great arteries, as you see here, or single ventricle congenital heart disease. This is an example of pulmonary atresia with intact ventricular septum, or the arrhythmia patient that we were looking at a little bit earlier. So what many centers use, including Children's National, is a level of care system. And what we do as part of this level of care system is try to anticipate the physiology and take into consideration the gestational age, the method of delivery, the delivery location, and what type of support, if any, is going to be necessary in the delivery room. This has been published. This comes from the American Heart Association. This comes from a study that was written by Dr. Mary D'Onofrio, who's the chief of fetal cardiology at Children's. This was the initial publication from our center regarding this level of care system. And again, you can see all of these aspects that we were talking about. What is the expected physiology? What are the delivery recommendations in terms of location and gestational age? And what kind of support is going to be necessary in the delivery room? So let's look at that first example, a complete atrioventricular canal. Despite the fact that this is an important form of congenital heart disease, most babies with this type of ventricular level shunt do not experience any sort of perinatal compromise from their heart abnormality in those first few days, weeks, and on occasion even months of life. So examples here are VSD, complete AV canal. So in terms of gestational age, there's no reason that a baby like this can't deliver at term via vaginal or cesarean delivery, whatever is appropriate for that mother. The delivery location can certainly be at the local hospital. And in terms of delivery room planning, there's no special care that's needed, but it is, of course, very important to arrange patient follow-up. Moving on to level of care 2 here. So this is a fetus with pulmonary atresia with intact ventricular septum. So just to orient you a little bit, posterior, anterior, here's the left ventricle, here's the right ventricle. This is a spectrum of congenital heart disease, but oftentimes it is a form of single ventricle congenital heart disease. The right ventricle in this case is very small, and importantly, when we image the aortic arch, so here's the aortic arch, here's the flow around the aortic arch, and here's this red here in the area of the ductus arteriosus. That represents reverse flow in the ductus arteriosus, which basically defines this as ductus arteriosus-dependent pulmonary blood flow congenital heart disease. So we know that a baby like this is going to require prostaglandin to maintain patency of the ductus arteriosus and maintain pulmonary blood flow after this. So again, this is level of care 2. Many forms of single ventricle congenital heart disease, severe tetralogy of Fallot with ductal dependence can fit into this spectrum. So in terms of the gestational age, we typically think of 39 weeks as being appropriate with a planned induction or, if necessary, a repeat cesarean section. 39 weeks is just recommended so we have a little bit more control over the delivery, although if the child should have, or the mother should happen to go into labor sooner, then the plan doesn't really change too much. The delivery location can be a local hospital with transport to the surgical center. We do recommend that a neonatologist is present and obviously prostaglandin be ready as needed. But it is important to note that delivery can be at the local hospital, and even though that this is important single ventricle congenital heart disease, if an infant is appropriately started on prostaglandin in an efficient way, there is no reason to expect any significant instability. So moving on to level of care 3. So this is an example of an arrhythmia, and you may note that the ventricular rate is quite low here. If you look up here at the atria, you can see that they're squeezing more often than the ventricles. So this is an example of complete heart block. This is what it looks like in M mode. Again, here are the atrial contractions, and here are the ventricular contractions. So here we're getting into a physiology where we are concerned that there may be instability that requires immediate specialized care. So examples include forms of single ventricle congenital heart disease with a restrictive atrial septum, transposition of the great arteries with a restrictive atrial septum, an arrhythmia where we're concerned about diminished function or perhaps even high drops. And here we think about a planned induction between 38 and 39 weeks or a cesarean section if there's a fetal compromise. There is a little bit of wiggle room here, and of course we're always taking into account fetal lung maturity in terms of the delivery planning. So there's always a discussion about risk and benefit. In terms of delivery location, we do suggest a hospital near or adjacent to the surgical center. And in terms of delivery room planning, those individuals and medications that should be there really depend on the specific disease, but usually a neonatologist, cardiologist, a cardiac intensivist if necessary, and medications as necessary. In the case of diminished function or a slow heart rate, inotropes or chronotropes are made available, and of course if there's additional ductal dependence, prostaglandin is recommended as well. So moving on to level of care 4, and as you might imagine, there are fewer patients in level of care 3 and level of care 4 than there are in 1 or 2. So these tend to be rarer circumstances, but this is one example that I showed earlier. This is total anomalous pulmonary venous connection of the infradiaphragmatic type. So you'll recall that rather than connecting to the left atrium, those pulmonary veins drain by a large vein below the diaphragm, through the liver, and come back up to the right atrium. And unfortunately, particularly in this type, there can be significant obstruction as those veins try to re-enter the right atrium. So, so much so that there can be significant pulmonary edema and low cardiac output immediately after birth. This is another example, hypoplastic left heart syndrome. So we all know that hypoplastic left heart syndrome is a form of single ventricle congenital heart disease. And importantly, in this section, we see that pulmonary veins return to the left atrium. They cannot go into the left ventricle because there really is no left ventricle to speak of. So all of that oxygenated blood must, by definition, cross the atrial septum, as you see here. But there are rare circumstances where, for whatever reason, the atrial septum becomes restricted or intact in utero, so that pulmonary venous return, that red blood, has nowhere to go. And after birth, when pulmonary vascular resistance falls, the left atrial pressure goes way up, there's pulmonary edema, low cardiac output, and babies like this need urgent or emergent cardiac catheterization with a septostomy to open the atrial septum, and or an urgent or emergent stage 1 Norwood surgery. And these are associated with high mortality. So if we identify a disease like this, this really puts us into that level of care 4. So again, some examples, or in terms of the physiology, excuse me, this is instability requiring immediate cardiac catheterization or surgery. Examples are hypoplastic left heart or transposition with intact atrial septum, an arrhythmia with high drops, obstructed total veins, as I just showed. Typically, we think about cesarean section between 38 and 39 weeks. Again, always considering that risk-benefit ratio in terms of fetal growth and fetal lung maturity. We think about delivery at the surgical center in the operating room. Again, these are babies in whom we think cardiac catheterization or surgery are going to be necessary immediately. And again, the team is going to be dictated by the specific disease, but it's often a multidisciplinary team. This can include cardiac catheterization specialists, cardiothoracic surgeons, ECMO support if needed, and of course, appropriate medications anticipated based on the disease that's identified. So that's the level of care system that we utilize at Children's National. And one thing that I wanted to mention is that this is always evolving. There are newer and newer techniques in terms of assessing the fetal physiology. This is one thing that we recently published from our center, is that maternal hyperoxygenation testing can be used to assess fetal pulmonary vasoreactivity in utero. So for example, in transposition of the great arteries, some fetuses do have reactivity of the pulmonary vasculature. And this is a normal response you can see at baseline. This is the spectral Doppler pulsed wave pattern here. And with hyperoxygenation, there's actually increased flow into those pulmonary arteries. This is normal, but it is important to note that some fetuses with transposition of the great arteries, we don't know which ones or how exactly to predict this, do not have this normal reactivity. And it may be that those fetuses are at greater risk for low oxygen and perinatal compromise. Here's another slide, again with transposition of the great arteries. And this is really fascinating in that some babies with transposition of the great arteries, we can actually get a sense for what their atrial septum will do after birth. This is at baseline. This is left atrium and right atrium. And here we can see there's kind of the usual right to left atrium foramina valley flow. But with maternal hyperoxygenation, there's actually left to right atrial flow, presumably because of increased left atrial filling. And some of that blood goes from left to right there. So this gives us the sense that the atrial septum may not be restrictive after delivery. And this is hopefully will be the subject of a multi-center prospective study in the very near future. So in terms of communication, that is absolutely key when we identify a congenital heart abnormality, and there is no identifying information here, but I wanted to give you a sense of our fetal heart program log. So as you can see here, these are all of the diagnoses of patients upcoming with significant congenital heart disease. We have our obstetricians and MFMs listed here. We have the level of care listed here, as well as the plan. And we circulate this out with an email as well that gives information to all relevant providers in terms of the plan. And this is always password protected, of course. But our fetal heart program coordinator, Cami Todd, who is absolutely amazing, will send this out and gives all providers an opportunity to be aware of a patient with a congenital heart defect and the plan after delivery. It really enhances communication. In terms of the benefits of prenatal diagnosis, I know some of them are probably obvious from what I've shared with you here so far. And again, this is the type of thing that could take up many hours, but there are essentially many, many benefits to prenatal diagnosis. And here is just a partial listing of many kind of papers in the last 10 or 15 years or so. Less preoperative cardiac catheterizations, use of antibiotics, fewer emergency and delayed surgeries, better ventricular function, better acid-base renal and respiratory status, decreased need and cost for critical care transport, shorter preoperative mechanical ventilation, lower risk for poor neurocognitive outcomes. Decreased mortality is always a tough one to get a handle on, but there's certainly a number of papers that do suggest that's the case. Decreased care cost overall, the opportunity for the family to consider not continuing the pregnancy, and the opportunity to mitigate cardiac disease during fetal life. And this is to say that there are rarely some diseases that can be intervened upon during fetal life, particularly arrhythmias and, on occasion, some forms of structural congenital heart disease. So now I want to kind of wrap things up a little bit with a tale of two transpositions. We're going to return to that. And this is part 2 here. So this is transposition number 2. This patient also had good prenatal care. And what I want to show is that this is the 4-chamber view here. So this is left ventricle and right ventricle. And again, this looks for all the world like a healthy and normal heart. I do want to point out that this is a moving clip, so at least we can get a good sense of the function. But then In our next clip, we sweep up to the outflows. And again, I showed this picture earlier, but again, you can see most importantly that there is a parallel arrangement of those great arteries, which is pathognomonic for transposition of the great arteries, or malposed great arteries, as would be the case with double outlet right ventricle. But again, this is a very important and significant finding. So we've identified here in this particular clip that there is transposition of the great arteries. But we can actually take that one step further. So this is back in our 14 review, and maybe some of you astute sonographers out there notice this, but I want to take a closer look at the atrial septum. So this is the right atrium, this is the left atrium, and you can see here this is the septum primum, or what will eventually become the atrial septum, and it's actually really quite tethered down. This should be kind of floating out here into the left atrium, but it looks like it's kind of stuck already. By way of comparison, this is what that normal fetal foramen valley should look like. I showed this a little bit earlier too. It's so thin and mobile you can barely see it here, again comparing to that kind of one that's tethered down here. So this certainly raises concern that after delivery there might be restriction of the atrial septum, or perhaps it'll even become intact after delivery. Again, that would prevent mixing of oxygenated and deoxygenated blood. So this baby delivered in a hospital adjacent to Children's National. It was a vacuum-assisted vaginal delivery. There was, as expected, important and severe cyanosis. The baby was immediately intubated and started on prostaglandin. Echocardiogram was performed in the delivery room, which confirmed transposition with a nearly intact atrial septum. So just to remind us of the distances we were talking about on the first case, well, these are the distances we were talking about in the second case. So transport was basically from over here at Washington Hospital Center over to Children's National Medical Center, which is about a 5 to 10 minute ride or so. The baby was transferred immediately to the Children's National CICU. The catheterization team was ready. The baby had a septostomy in just 93 minutes. An arterial switch operation was performed at 4 days of life, and that baby had a stable postoperative course and was discharged to home at 13 days. So I hope that gives a little bit of a sense of the benefits of prenatal diagnosis and what we're doing over in fetal cardiology, and also our level of care system, which helps babies make the transition from prenatal to postnatal, hopefully in a healthy way. So I'm going to stop there and just open it up for any questions that anybody has. Anybody have any questions? And just to make it known, so we see patients in our fetal cardiology clinic basically 5 days a week, and occasionally if necessary on a weekend. Happy to do that as well. Families are typically referred in from a maternal fetal specialist, and we have our own fetal heart program coordinators that can help arrange visits for families. All right, if there are no questions, we will wrap it up there. Thank you so much for listening, and feel free to reach out to me personally via email or phone, and that information is going to be sent out in the next few minutes or so. I'm always happy to see patients or discuss patients or meet with a family. So thank you so much for listening, and have a great day.